Hyponatremia is one of the most frequently encountered electrolyte abnormalities in clinical practice and is associated with increased morbidity and mortality. Accurate diagnosis is essential because management depends entirely on the underlying mechanism rather than the sodium value alone. This session focuses on a structured, physiology-based approach to evaluating hyponatremia in adults. Hyponatremia represents a disorder of water balance rather than sodium deficiency. In most patients, the kidney fails to excrete free water appropriately due to persistent secretion of arginine vasopressin, also known as antidiuretic hormone. Understanding this pathophysiologic principle is fundamental to diagnostic reasoning. The evaluation of hyponatremia begins with key questions. The nurse must first determine whether the low sodium reflects true hypotonic hyponatremia or an artifact. Clinical urgency must also be assessed, as patients with acute or symptomatic hyponatremia may require treatment before full diagnostic evaluation is completed. Serum tonicity determines the movement of water across cell membranes. Most patients have hypotonic hyponatremia. However, isotonic and hypertonic forms must be excluded early, as they require entirely different management strategies and do not involve excess free water. Pseudohyponatremia occurs when laboratory measurements are affected by abnormal plasma solids, resulting in falsely low sodium values. Hypertonic hyponatremia, most commonly due to hyperglycemia, occurs when extracellular osmoles draw water out of cells, diluting serum sodium without true water excess. Once hypotonic hyponatremia is confirmed, further evaluation focuses on identifying why the kidney cannot excrete water. At this stage, attention shifts to assessing extracellular fluid volume and renal handling of sodium and water. Clinical assessment of volume status is challenging but essential. Signs such as edema, orthostatic hypotension, and jugular venous pressure provide clues, but laboratory data are often needed to support bedside findings. Accurate volume classification narrows the differential diagnosis significantly. Urine osmolality is a critical investigation in hyponatremia. A maximally dilute urine indicates appropriate suppression of ADH, while concentrated urine suggests persistent ADH activity, which is abnormal in the presence of hyponatremia. Urine sodium concentration helps distinguish between renal and extrarenal causes of hyponatremia. Low values suggest sodium retention due to decreased effective circulating volume, while higher values indicate inappropriate renal sodium loss or euvolemic states such as SIAD. Classifying causes by volume status allows for a systematic approach. SIADH is the most common cause of euvolemic hyponatremia, while heart failure and cirrhosis dominate hypervolemic states. Each category reflects different pathophysiologic mechanisms driving ADH release. Certain clinical situations deserve special attention because they mimic other forms of hyponatremia. Thiazide-induced hyponatremia often resembles SIAD, while low dietary solute intake limits the kidney's ability to excrete water despite normal ADH suppression. Nurses play a pivotal role in recognizing hyponatremia, initiating appropriate investigations, and monitoring for complications. Understanding the diagnostic framework helps prevent misclassification and reduces the risk of inappropriate or dangerous correction strategies. Please like, share, and subscribe, and leave your questions as comments.